What is peptic ulcer disease? Peptic ulcer disease is a disease where there is ulcer, most commonly seen in duodenum, followed by gastric ulcers, that is in stomach, and then the ulcers in gastroesophageal junction. What is the definition of ulcers, that is peptic ulcers? Break in the mucosa, which can be seen endoscopically, or there is histological evidence of break in the mucosa with the till the level of submucosa is called peptic ulcer disease. So peptic ulcer disease is a disease where there is break in the mucosa with a visualization of the lesion on endoscopy, and there is histological evidence of involved depth till the submucosa. What is the pathophysiology of this condition, peptic ulcer disease? In stomach, inside we have some damaging factors and some protective factors. The damaging factors are HCl and pepsinogen. Even though HCl here is damaging factor with respect to peptic ulcer disease, HCl is an innate immune response to fight back the infections. It prevents the proliferation of microbials. The HCl pH, stomach pH, is an innate immunity in itself. With respect to peptic ulcer disease, it's a damaging factor. The HCl and then the pepsinogen enzyme, the protein enzymes which can damage the proteins, are the damaging factors. The protective factors are, we have pre-epithelial protective factors, epithelial protective factors, and subepithelial protective factors. The pre-epithelial protective factors are mucus and bicarbonate, which are secreted from foveolar cells or the epithelial cells of the stomach. The epithelial protective factors are intercellular tight junctions, prostaglandins. The prostaglandins which in turn stimulate the secretion of bicarbonate and mucus from the epithelium, and also the prostaglandins will cause the regeneration of epithelium. Then we have sub-epithelial protective factor. Those are bicarbonates from the blood. The bicarbonates from the blood reach the epithelium, which are secreted into pre-epithelial layer. So bicarbonate from the blood flow, and also the blood will remove the toxic metabolites which are present at the level of epithelium of the stomach. These are the pre-epithelial, epithelial, and subepithelial protective factors. The imbalance between damaging and protective factors causes peptic ulcer disease. So let's see what are the things which increases the damaging nature of the damage of the mucosa of stomach. We have the most common causes. Those are H. pylori infection, the Helicobacter pylori infection, and NSAIDs intake. The least common or the less common causes are smoking, which causes reduced blood supply and reduced epithelial regeneration, thereby causing ulcer. Alcohol intake. The alcohol is a direct damage to the mucosa, thereby causing peptic ulcer disease. So alcohol directly irritates the mucosa of the stomach. The Zollinger-Ellison syndrome, which is a gastrinoma secreting tumor. The gastrin, we know, it stimulates the parietal cells to secrete more and more HCl, thereby damaging the epithelium and causing ulcer. We have severe burn and trauma, causing ischemia and leading on to ulcer called as Curling's ulcer. We have intracranial disease, which increases the vagal outflow from the CNS. The increased parasympathetic stimulation causes increased secretion of HCl and thereby causing Cushing's ulcer. Then we know that the most common causes are NSAIDs and H. pylori. Why NSAIDs causes peptic ulcer disease? The NSAIDs causes peptic ulcer disease by reducing the prostaglandin at the level of epithelium, which has secondary effects which we already discussed. The direct irritation, the NSAIDs tablets when we take, it dissolves in the stomach mucosa and it has direct irritating effect on the gastric mucosa, causing peptic ulcer disease. The H. pylori infection. H. pylori is an important infection. So we'll discuss about H. pylori briefly. What is the pathophysiology of H. pylori infection? Before that, H. pylori is a gram-negative bacteria, which is catalase positive, oxidase positive, and urease positive. Important. What is the pathophysiology of this disease? The H. pylori, it is colonized in almost 100% of us. It first occupies the antral region of stomach. Following that, it can migrate to body or fundus. Because it has flagella, it can migrate upwards. The H. pylori, Helicobacter pylori, doesn't invade the epithelium. It's present at the mucous pre-epithelial layer and causes the damaging effects. Please note, the H. pylori is protective against some diseases like GERD, gastroesophageal reflux disease, Barrett's esophagus, and adenocarcinoma of esophagus. So, we should not simply eradicate H. pylori in all the patients. If we are confirmed that H. pylori is causing ulcer or any other secondary diseases, then only we should eradicate H. pylori infection. Now, how this H. pylori is causing peptic ulcer? It increases the damaging factor, that is HCl. How so? It releases urease. The urease enzyme will convert urea into ammonia. This ammonia is alkaline in nature. This increases the pH of the stomach. The increase in pH of the stomach will stimulate the G cells of the antrum to release gastrin. This gastrin is responsible for stimulation of secretion of HCl by parietal cells. So thereby, by increasing damaging factor, H. pylori can cause peptic ulcer disease. We have the impairment of pre-epithelial barrier. How? The protease and phospholipase enzymes secreted by H. pylori bacteria will break the mucin layer, which is a pre-epithelial barrier. The epithelium of the stomach can be injured by cytotoxins secreted by H. pylori. Those are Vaccae and Caguae. And also, the Helicobacter pylori bacteria will cause an increase in pro-inflammatory mediators like interleukin-6 and TNF-alpha, tumor necrosis factor, causing influx of inflammatory cells like B cells, T cells, macrophages, causing damage to epithelium, thereby leading to peptic ulcer. This is about the pathophysiology of H. pylori. Now, what are the clinical manifestations that we see in these patients? The clinical manifestations seen in case of H. pylori causing peptic ulcer diseases, epigastric pain. Characteristically, we see nocturnal pain. The patient getting up from sleep and due to pain, it's called as nocturnal pain, seen most commonly in duodenal ulcer. The pain is exacerbated on fasting and relieved on intake of food. So, along with peptic ulcer disease, 10% of patients, we know 100% it's colonized. Out of those 100% of us, 10% of them will develop following diseases. In this 10%, 70 to 80% will develop duodenal ulcer, the features of which I mentioned. The 50 to 60% of them will develop gastric ulcer. They will have epigastric pain, episodic epigastric pain. Here, the intake of food will aggravate the symptoms due to production of HCl. We can have carcinoma of stomach and maltoma associated with H. pylori infections in some subset of patients. Now, how to manage this condition, H. pylori? The investigations we have: biopsy. We do endoscopy, see the lesion, and take biopsy from the lesion. If we perform rapid urease test, thereby we can confirm the existence of H. pylori infection. And also, we can do culture using Skirrose media or blood agar. We can eradicate the eradication of H. pylori is confirmed by urea breath test or stool antigen test. Now, how to treat this H. pylori infection? We have OCA or OCM regimen, which is given for 14 days. O stands for omeprazole 20 mg BD. C stands for clarithromycin 500 mg BD. A stands for amoxicillin 1 gram BD. And M stands for metronidazole 500 mg BD. It is given for 14 days, that is 2 weeks. Following the treatment period, we'll wait for 4 weeks. After this waiting period, we check for eradication by checking urea breath test or stool antigen test. If the disease is eradicated, we are happy. Patient is happy. All are happy. The patient will be symptom free. If it is not eradicated, we try 4-drug regimen, that is OBTM regimen, where you use omeprazole, bismuth subsalicylate, tetracycline, and metronidazole. This is about H. pylori infection. We were discussing about ethopathophysiciology of peptic ulcer disease, under which we saw most common causes NSAIDs, H. pylori. Least common causes we saw. Under most common causes, I discussed extensively about H. pylori infection. Let's proceed on to clinical manifestations of peptic ulcer disease. We have most common symptoms, that is complained by patients, are recurrent abdominal pain. The abdominal pain is characteristically localized to epigastrium. The patient has epigastric pain, which has burning character, and the pain radiates to back and thorax. The patients with duodenal ulcer, which is the most common ulcer caused by seen in peptic ulcer disease, most common site where peptic ulcer is seen is the duodenum, first part of duodenum. The patients with duodenal ulcer will present with nocturnal pain. That is, the patient will be sleeping aram say midnight, 2 a.m., 3 a.m. He will get up due to pain, and he will cry due to pain. Then following nocturnal pain, we have the abdominal pain in relation to food. If the patients take food, if it is relieved, the abdominal pain is, if it relieved on food, causes duodenal ulcer. In some patients with gastric ulcer, the intake of food aggravates the abdominal pain. And also, the pain is periodic or episodic. What's the meaning? The patient is untreated, the patient will have episode of pain for 2 to 8 weeks. Following that, he will be symptoms free, eating all chili, chocolate, alcohol, and smoking. After that, he will again have a relapse, again have an episode of pain. This is called as periodic or episodic pain. Along with pain, some patients complains of retrosternal burning sensation, increased salivation, acid regurgitation into the throat or mouth, and also some patients complains of bloating. What are the complications of peptic ulcer disease? The ulcer may erode gastroduodenal artery, most commonly leading on to upper GI bleeding. The ulcer may perforate, causing peritonitis. And also, following ulcer, if the ulcer has developed in the antral region or pyloric region, there can be stenosis called gastric outlet obstruction. Rarely, the ulcer may undergo malignant transformation, causing gastric carcinoma. What is the management of peptic ulcer disease? Under investigations, we have endoscopy, which is more sensitive and specific investigation. We perform upper GI endoscopy. We see the lesion, that is ulcer, which can be most commonly in the first part of duodenum or at the lesser curvature of stomach. Following the visualization of the lesion, we don't sit simply. We take biopsy to rule out malignancy, and also we check for H. pylori infection by doing rapid urease test. Please note, biopsy is compulsory if the patient has gastric ulcer, because the gastric ulcer is most commonly maybe due to the gastric carcinoma also. We should rule out malignancy in case of gastric ulcer. We can also perform endoscopic USG, endoscopic ultrasound, to see whether there is any enlarged lymph nodes if the patient has associated malignancies. The test for H. pylori are urease, breathed stool antigen test, and culture with Skirros medium, which we already discussed. How to treat these patients? The treatment, we have medical treatment and surgical treatment. The medical treatment is the first line of treatment that we give to our patients. First, we request the patients to avoid alcohol and smoking and avoid NSAIDs if possible. And then we can give antacids like aluminum hydroxide and magnesium hydroxide. We reduce the damaging factor, that is HCl, by giving antihistamines, the H2 receptor blockers like ranitidine, 150 mg BD or 300 mg at night. Or we can give proton pump inhibitors, which irreversibly blocks H plus and K plus ATPase, thereby reducing the HCl secretion. That is omeprazole 20 mg per day or pantoprazole 40 mg per day. The duration of antihistamines are, in case of duodenal ulcer, we give it for 4 weeks. In case of gastric ulcer, we give it for 6 weeks. Also, we can give cytoprotective agents like sucralfate, 1 gram QID 4 times a day. This sucralfate will go to the stomach, form a nice paste over the ulcer, protecting it from further damage from HCl and thereby improving the chances of healing of the gastric ulcer. If the patient is medically refractive, if the patient is refractory to medical therapy, or if the patient has complications, we go on with surgery. Those are chronic. If we have chronic non-healing ulcer, we will perform partial gastrectomy with Billroth 1 reconstruction. If the patient has perforation, we will perform modified Graham's patch repair. This is all about peptic ulcer disease. To summarize, peptic ulcer disease is a disease where there is mucosal break, which is endoscopically visible, or there is histological evidence of depth until submucosa. The pathophysiology, we saw damaging factors and protective factors imbalance leading on to peptic ulcer disease. The damaging factors are HCl and pepsinogen. Protective factor, we have pre-epithelial factors like mucus and HCO3 minus, that is bicarbonate. Epithelial factors like prostaglandins, intercellular tight junctions, and subepithelial factors like blood supply. The most common cause impairing this damaging and protective factor are NSAIDs, followed by, and also we have H. pylori. The H. pylori we discussed extensively. H. pylori is a triple positive bacteria, which is catalase positive, oxidase positive, and urease positive. The pathophysiology basics we saw. In 100% of us, almost 100% of us, we have colonization of H. pylori in Indians, where the colonization, usually the bacteria attaches to the antrum or pyloric region, then followed by migration into the, it can migrate upwards into the body and fundus. In 10% of them, it can lead on to duodenal ulcer, gastric ulcer, stomach carcinoma, or maltoma. Now, it is protective. H. pylori infection is protective of the GERD, Barrett's esophagus, and adenocarcinoma of esophagus. How it causes peptic ulcer? By increasing damaging factor, that is HCl, by impairing pre-epithelial barrier, that is mucin, by protease and phospholipase, by impairing epithelial layer, by producing cytotoxin like Vaccaea, Cagia, and increasing pro-inflammatory substances. The clinical manifestation is epigastric pain and also nocturnal pain, which is relieved on food and aggravates on fasting. We have management, that's investigations. We perform biopsy, rapid urease test, and for checking eradication, we can perform urea breath test or stool antigen test. Under treatment, we have OCA or OCM regime, and if the patient doesn't have eradication, we can perform OBTM regime. Then we saw clinical manifestations of peptic ulcer disease, that is recurrent abdominal pain, epigastric pain, burning character radiating to back and thorax. Along with the patient may have nocturnal pain. The pain relieved on food. In case of duodenal ulcer, aggravate on gastric ulcer. The pain is episodic or periodic. Associated with that, the patient may have retrosternal burning pain, increased salivation, acid reflux, and bloating. The complications, we saw upper GI bleeding, perforation, gastric outlet obstruction, and malignant transformation. Under investigations, we have tests for H. pylori, that's urease, breath test, stool antigen, and culture. Most sensitive and specific test is endoscopy, followed by biopsy. Then we can rule out malignancy and test for H. pylori infection. Endoscopy ultrasound can be done to look for enlarged lymph nodes in case of malignancies. The treatment we saw, we avoid the things which are causing damage. And also antacids, we can give aluminum hydroxide, magnesium hydroxide. We reduce HCl secretion by giving H2 blockers or proton pump inhibitors. We can give cytoprotective agents like sucralfate if the patient is refractory to medical treatment or has complications. In the case of chronic non-healing ulcer, we can perform partial gastrectomy with Billroth 1 reconstruction, and if the patient has perforation of the ulcer, we perform modified Graham's patch repair. Thereby, we are ending the discussion on peptic ulcer disease. Thank you for listening.